Okay, we're back for part 3, which is birth procedures, medical management. When the fetus needs help becoming a newborn, it's time to have a baby right now. And this is vacuum assisted delivery, forceps assisted delivery, and cesarean section. Now, vacuums and forceps can and are used in C sections. At times, it is more common to see the vacuum used to assist than the forceps in both cases, but they are also used in vaginal delivery. When do we use these emergency or these hastening of delivery? It's indicated when the birth needs to happen immediately or when mom is too tired to continue. She's just not going to push anymore, no matter what you do, or she's not pushing effectively. She's been pushing for many hours and she is too tired to continue. The most common indications for the vacuum and the forceps, definitely non-reassuring fetal heart rates, like your bradycardia decels at the end of second stage. And baby has to be fairly low in order to apply vacuums or forceps in most cases. For C-section, it can happen really at any point. An emergency C-section can happen like a prolapsed cord, even if she's only 5 centimeters. Or if we have failure to descend, mom's been pushing for 4 hours, baby hasn't moved. Or we have a failed operative vaginal delivery. Vacuums and forceps in a vaginal delivery are called operative vaginal deliveries. So if we fail at a vacuum, we don't try the forceps next and then try pushing some more. We go back for a C-section. Same thing with forceps. So, you try one method of assistance according to the literature. You may see variations in practice, but be aware that the best evidence suggests that a mixed operative delivery vaginally is not a good idea in terms of fetal outcomes, or neonatal outcomes rather, because they won't be fetuses for much longer. So other things, we can see worsening maternal conditions. So examples, if mom has chorioamnionitis and her uterus isn't pushing effectively and she's not, but the baby's right there, you could do vacuum, you could do forceps. If she's remote from delivery and we can't get it out vaginally at all, we'll go back for a C-section. Mom has an eclamptic seizure. We need to have a baby now and fix her and the baby. We should talk a little bit about what to do in an eclamptic seizure at some point, but not right now. Really, the decision to do vacuum, forceps, or emergency cesarean is not up to the nurse at all. It's not in our scope of practice, nor should it be. But a physician really should consider the risks or benefits. And I say that because a midwife or other provider, family practice professional, somebody like that, it should be the OB that makes this decision, in consultation maybe with the midwife, or sometimes family practice docs deliver babies, although I haven't seen it in many years. So let's go to vacuum-assisted vaginal delivery. It's application of suction to a fetal head to effect delivery. Sounds great, doesn't it? Just suck them right out. It's actually pretty brutal when you see them in person. And mom still has to push. She is not off the hook. She must push for this to be effective. And no nurses or anybody else applying pressure at the top of the uterus or the fundus. That's a bad, bad, bad idea. You should see progressive descent within 2 pulls, and usually you do. Sometimes the suction device pops off the head. It makes a really wet, yucky sound, and it kind of gives you a sick feeling when you hear it. The Kiwi says no more than 2. The Mighty Vac, I'll show you those in a minute, says no more than 3. But really, definitely, if that pops off more than twice, you're really probably not best off going forward. The risks of a vacuum extraction are mostly to the baby, and we have a cephalhematoma. That is swelling on one side. You'll see it more in newborn. I think it was in the newborn assessment video. It's a little collection of blood under the scalp. It's not life-threatening, but it can put the baby at increased risk for jaundice. And then we have, in extreme cases, I have seen this. They are not benign things, vacuums. If they are applied incorrectly or for too long or too many pulls, they can cause fetal brain injury or fetal death. So seriousness of the situation. So this is a Kiwi. Kiwi has that little foam cup, and what I love about the Kiwi is you hand that to the provider. You put it on the sterile field, and it is all in their hands. It's a palm pump. So with one hand, they're holding the suction, and with the other hand, they're pulling on this thing, and they're, kind of getting the baby out as mom pushes during a contraction. You want to maximize your chances of success. You don't want to do it between contractions. You don't want to do it without maternal pushing. But I like it. You see these little, let me get my pointer out. I don't love this pointer, but whatever. You see how there's a red zone and a green zone? Got to keep it green. If it's here in the white, it's not doing anything. But if it's here in the red, you're putting too much pressure on that baby's head and risking brain injury. So you want it in the green, keep it green. This here is a MightyVac. It is actually, MightyVac makes this same device without that gauge with the green dial and the red zone for bleeding breaks. I bought one on Amazon Prime once for a little simulation exercise with a class. But it attaches to this tubing, and then there's a little suction cap. There are all these different suction caps that can fit with the MightyVac. And the provider now has two hands free. This little handle here for pulling, applying traction. And then the nurse is the one who pumps this up into the green zone. If that's your job, this is a quick release handle right here. You have to be the one responsible for making sure that the suction pressure is appropriate for that baby. And they'll tell you, take it all the way to the end of the green. Yeah, okay, whatever. As long as it's in the green, it's adequate suction. Sometimes the thing, like I said, will pop off because the baby's scalp is so wet. But sometimes it's just that it pops off with the suction fully intact. And, you want to document that. So nursing responsibilities, as I said, this is not something that the nurse will do without a provider. This is a provider's job. You're going to make sure that that patient's bladder is empty. Now, a lot of times the provider will do the straight cath. You just put the catheterization stuff on the field, and they do it right before they apply the vacuum to make sure there's no bladder injury. You're going to monitor the fetal heart rate. So it's important for you to be able to get good, reliable fetal heart tones and make sure this baby's actually tolerating this procedure. You're going to note times. It's helpful in this situation to have somebody who's your documentations nurse, because we don't all have enough hands to do everything. We're helping mom push. We're encouraging that. We're looking at the vagina for progress. So we don't necessarily have a free hand to write down, okay, vacuum applied at 10:36. This is when you want somebody in the room who's documenting while you're doing stuff. So time of application, when it was applied, the length of the pole, when it came off, and whether or not you see descent. Okay, and then the total number of poles you're going to want to note. And you'll see like time of delivery, just like you would for another delivery. But for the MightyVac, you're responsible for staying in the green zone, just like I said, and you got to make sure NICU is present at delivery. If that baby needs some help coming around, you want to make sure there's somebody there who has enough hands to do that. And this is a baby right here with a vacuum mark. Vacuum marks look awful, but they usually do disappear within about a week. The scalp can be abraded. If there's an open portal for infection, then we might want to apply some bacitracin with a pediatrician's order. Sometimes there's a capit. Like this isn't like if it were in 3D, you'd see like a little swelling there. This is a baby who's had forceps. I'm going to show you what forceps look like, and you'll see it's like a pattern bruise in the shape of the forceps. Make sure mom knows that goes away. Forceps assisted vaginal delivery. These are less common because fewer physicians are trained in how to do them. We do have a number of physicians. In most facilities, there's somebody who knows how to do forceps, and they usually prefer it. It's about 1% of all vaginal deliveries are assisted with forceps. It does require very specialized training. During residency, usually people will get that training. If they don't have it, they'll revert to a vacuum. There are three types of forceps, like three basic types of forceps. They're all different, like McGill's and Simpson's and all that stuff. But outlet forceps we're going to do while the baby is crowning. And they just, that's the preferable situation when the baby just needs a little help to come out. You need to you don't need to. The provider needs to cut an episiotomy to make room for this. And a lot of times it will be a mediolateral to minimize, not prevent, because it could still happen, minimize the risk of extension into the rectum. There are low forceps, and these are fairly common as well. The baby needs to be at least +2 station for it to work, but the longer you have to pull, or the harder you have to pull to get the baby out by the head, the higher the risk to everybody is. And then you have mid forceps, and that's when the baby's engaged but not necessarily descended. Mid forceps, you'll find, are a lot less common than any of these. Usually it's outlet or low that you see. Risks are fetal head or face injuries. Like, that's a no-brainer. You can get a skull fracture, and then the facial injuries. You can, see some of that. Sometimes you see nerve injuries in the face. There is a small risk of brain injury. It is rare with forceps. I don't have statistics. I could look them up for you, but I believe that vacuums, maybe because vacuums are more common or more prevalent, have a higher risk of brain injury. But I would have to research that a little further to give you hard data. Fourth degree laceration of the perineum. That's when everything extends into the rectal lumen and you've got one big hole down there. And that is a tricky, tricky repair. But when I was on orientation, I did a forceps delivery with a nurse who would say, get the Gelpies. And the Gelpies were an instrument for repairing this. And I would say, what? And she'd go, that's what you use to repair fourth degree. I'm like, but they didn't start yet. And she goes, forceps fourth, forceps fourth. And I never forgot it, and neither will you. Mom can get perineal hematomas, and those need to be evacuated. She can have a bladder injury, and she can have long-term anal incontinence. Isn't that fun? If the repair isn't done skillfully. There can be damage to that rectal sphincter, and that can lead to the involuntary passage of flatus and stool. So it's not, again, something you want to take lightly. Hopefully a provider with a lot of skill won't have any of those bad outcomes. You'll just have a baby. And then we have some more interventions during second stage, and we're going to talk about episiotomy. I just kind of touched on it briefly, but an episiotomy is actually a little incision they make with scissors into the perineum to provide more space for delivery. I do have a picture on a slide that follows. The indications for an episiotomy, it used to be routine. They did it to every mom, every mom, especially first-time moms, and they would cut huge epises. Women would describe it as being cut from stem to stern, and they were usually mediolateral, which is, we'll talk about pros and cons of that. The old indication used to be, well, if we don't cut her, she'll tear. Well, true, but most tears are first or second degree. They don't go all the way through the belly of the muscle. And episiotomy is automatically like a third degree. And when I talk about the degrees of lacerations, which is like a slide that follows this in a few, a little bit later, it could even be in the fourth video, you'll see a laceration a lot of times heals better because it tends to be more superficial. Sometimes if it looks like the laceration is going to go upwards, where the repair would be difficult, like into the urethra or the periclitoral area, where mom might have like nerve damage lasting from that, they might cut an episiotomy, but not common. Really have reduced the risk of episiotomies because they aren't shown to prevent much, and they are sort of rough to recover from. They do reduce the length of the second stage. So if you need that extra bit of room to get that baby out a little bit quicker because maybe the fetal hearts are going down, that would be an indication. Or if you have a really tight perineum that just won't stretch and it's holding up delivery, and you're concerned about fetal well-being or maternal exhaustion, an episiotomy might be indicated. And then you have instrumental deliveries. When we do the forceps or the vacuum, they might need that extra bit of room to maneuver, and that would be another indication for episiotomy. So this is kind of what that looks like. You see here, that is a midline episiotomy. Okay. You know what? I will fix that slide in just a second. But you see it goes straight down the middle of the perineum. Okay. That is actually preferred by most providers. And students have a hard time understanding that. But if you know the musculature, if you ever look at a model of the muscles of the pelvic floor, you'll see that there's like a ligament here. You don't have to cut the muscle fibers per se. So it generally heals better, and it doesn't cause as much discomfort. Now, the disadvantage to that midline episiotomy is that if it tears all the way down, it can go into the rectum. So you do have the chance of extending into a fourth degree. This, where the scissors are going now, is a mediolateral episiotomy. So the advantages of a mediolateral episiotomy is that you can make a lot more room and not worry about going into the rectal mucosa. So if you're doing forceps and you don't want a fourth, you could cut that mediolateral. Some providers were trained to do it that way routinely, and that's what they do. But again, going back to the musculature, if you look at a diagram of the muscles of the perineum, you're cutting right into the belly of that muscle. It takes longer to heal. It hurts more. It usually extends a lot higher. So that's sort of the disadvantage. And you do get greater blood loss because you're cutting a bigger incision. So that. And if you give me 1 second, I'm going to pause this and fix that slide so that you have it. Okay, and there you go. I mean, it's obscuring some of my text, but that's fine. But you'll see that it's less discomfort, it heals faster and better, and then the midline does, and the medial lateral, as I said, no rectal involvement and more room. And now we're going to go to cesarean birth as a topic. One more than a third, it's about 32% currently in the United States. That number was going steadily up all through my training as a nurse, or education as a nurse, sorry, through my practice, and then it kind of leveled off. There's a big movement in promoting vaginal birth because it is a major abdominal surgery. It does involve higher morbidity and mortality, but sometimes it's the safest and best option. There's a lot of talk about the number of cesareans being unnecessary, but in any given case, a provider is using their best judgment. Usually some are quicker to cut than others. But what drives the increase in cesarean birth, and I don't want to take too long to explain this, is the number of lawsuits that allege that a baby could have had a better outcome if they were delivered quickly. And the quickest delivery in most cases is a cesarean birth if you're not going to be able to get them out through vacuum or forceps. So a lot of providers will do a cesarean because if we don't know the outcome in advance, and we never do, hindsight's 2020, if they're nervous about a baby, they're going to go for the C-section. Nurses' responsibilities, we do pre-op education, you do intra-op education sometimes, and then post-op education on postpartum, but that's separate stuff. And helping her position for the spinal. We're also going to do the pre-op teaching as part of our education. We position the patient and monitor the fetal heart rates during the epidural and spinal placement. We kind of coach her through that. There needs to be a Foley catheter for this surgery. The bladder is superior to the uterus, so we don't want them to cut through it on their way there. Now, if you're circulating for this patient, you're going to maintain the sterile, you're going to watch the room and make sure that sterile stays sterile. That's your job. You're sort of the housekeeper there. And a lot of stuff goes on in C-sections that don't happen in other surgeries. There's a lot more family involvement, which is a good thing. But at the same time, they don't understand the procedure as a sterile procedure. And so sometimes we have to remind them, come over here, Dad, and look at the baby, but don't touch this blue thing. That's important. Monitor the traffic coming in and out of the OR. If somebody's bringing you supplies, for example, from out on the floor, you want to meet them at the door, maybe not have so much traffic in and out. And you want to notice if anyone accidentally breaks sterility and call attention to that and put a hard stop to that procedure. You might not make friends doing that, but you are advocating for your patient. You're going to manage equipment, so make sure that your suction is working. Make sure the bovie is this little thing that cauterizes blood vessels. Those of you who have been in C-sections in clinical have already seen it. It looks like a little pen. So you make sure that works and it's to the correct setting. If they need extra sutures on the field, the scrub tech or the scrub nurse will be sterile at that point. The scrub nurse's job, they have two jobs. They're going to assist the surgeon by handing them the equipment. They're sterile, and they're going to maintain the count with the circulator. But if you're circulating, you have to go and find all the stuff that's not sterile on the outside and open it sterilely on the field so that nothing is contaminated. Laps or lap sponges So you're going to make sure that they have enough of those and that they stay sterile. And then you do counts. We do a lot of counting in the OR because we don't want to leave anything in the patient accidentally. So people a lot of times will do a care plan on a C-section patient and say, well, what kind of nursing diagnosis? There's no nursing diagnosis you can use. Well, of course there is. There is a knowledge deficit related to perioperative course. Okay, so if we have deficient knowledge, we're going to do teaching. That's our intervention. Preventing injury. So we're preventing injury by inserting the Foley catheter. We are positioning the patient for the epidural. That prevents injury from improper placement of the spinal. We are going to monitor fetal hearts. That's promoting fetal safety. Then we're going to maintain and monitor the sterile field, risk of infection related to, open procedure. That's also part of your managing equipment, risk of injury, making sure that your bovie and your suction are set to the right things and that they're working, so that you have the equipment you need that the provider can perform the operation safely. So that's risk of injury. And then the counts are super important because it's risk of injury related to foreign body. And you're making sure that if you started with 25 sponges, you end with 25 sponges and none of them are still left in the patient. And that is the end of that video.